Now, next question. What should be the treatment of an 8 centimeter endometriotic cyst or endometrial cyst? Okay, so this is an image of an ultrasound showing a huge cyst, and this is an endometriotic cyst which can be a chocolate cyst of ovary. Okay. Now, in this question, let me tell you a few things I would like to mention here. The most common presentation of endometriosis. What is endometriosis? Presence of endometrial glands and stroma outside the uterine cavity, and most common site is the ovary, where it presents as chocolate cyst ovary. Another presentation of endometriosis can be peritubal or peri-ovarian adhesions, and third presentation can be the purple color, violet, red, velvety endometriotic implants in the peritoneal cavity, in the sigmoid colon, appendix, pouch of Douglas, anywhere. Okay, so these are the three forms of presentation of endometriosis. What is the most common symptom of endometriosis? Always remember, it is a pain. This they have already asked. What type of pain? Mostly it is congestive dysmenorrhea. Now, what is a classical triad of endometriosis? Classical triad of endometriosis is congestive dysmenorrhea, number 2, dyspareunia, that is painful coitus because of the endometriosis present in the pouch of Douglas, and like the third presentation can be infertility. So endometriosis is usually a disease of the reproductive age group. On per vaginum examination, uterus is usually normal size. There can be bilateral adnexal masses, or there can be tenderness in the pouch of Douglas. Uterus in these cases is retroverted and mobility is restricted. So that is what the findings you can get it. I again repeat, most common presentation is the pain, but that can be congestive dysmenorrhea. Otherwise, classical triad is dysmenorrhea, dyspareunia, and infertility, and usually it is a disease of the reproductive age group. On doing per vaginum examination, uterus is retroverted, normal size, and there is a mobility restricted. There can be tenderness in the pouch of Douglas, or you can find there can be bilateral adnexal masses, which is endometriotic cysts. Okay. Now, remember, if the presentation of the patient is adnexal masses and you are supposed to give the treatment, if the adnexal masses is less than 5 centimeters, then you have to do wait and watch, because if it is a reproductive age group, we want to conserve the ovaries for the fertility functions. So less than 5 centimeters, just wait and watch and do serial ultrasound. Okay. If the size of the cyst is increasing, or there is, like it is becoming symptomatic, then we might have to give the treatment. Now, if the size of the endometriosis cyst is more than 5 centimeter, then we have to go for ovarian cystectomy. Nowadays, fulguration and all is not preferred. So we can do ovarian cystectomy using the laparoscopy. Now, most of you should know that laparoscopy, the gold standard investigation for endometriosis is laparoscopy. Number 1, it is diagnostic. Number 2, you can do the treatment. Even you can do the adhesiolysis. Fine. So in this question, cystectomy, GnRH, needle aspiration, conservative treatment. So there is no role of conservative treatment since the size of this endometriotic cyst is more than 8 centimeters. Needle aspiration will not work, because whenever there is any cyst in the body, it has to be taken out along with the cyst wall, because the chances of recurrence is high. GnRH is just going to be the medical treatment. So here I am going to do cystectomy, and preferably laparoscopically. Okay. Now, Few things I would like to mention it here. This is endometriosis on ultrasound, and this is a laparoscopy image of chocolate cyst, and this you can see so much of adhesions. This is around moderate to severe endometriosis. So why infertility occurs in endometriosis patients? Because there is immobilization of fallopian tube due to adhesions, and the anatomy very much distorted anatomy. So fimbria will not be able to pick up the ovum, hence infertility. Okay. Now, this is severe endometriosis. You can see in the pouch of Douglas, and there's a chocolate cyst ovary. So, this is very, very severe endometriosis. I am not going to do any surgery in this case because it can lead to post-operative complications like bladder injury, like bowel injury. So, I am not ready for that. If the presentation of my patient in this case is infertility, then the treatment of such cases will be IVF. Okay. Now, this is just very, very quickly because endometriosis is a very, very important topic, and every exam, whether you're writing an FMGE exam, whether you're writing a NEET PG exam, or whether you're writing an UPSC exam, or whether you're writing an INI-CT exam, endometriosis is a very, very upcoming topic because 40 to 50% cases of unexplained infertility, the cause is endometriosis. So, before you label the patient as unexplained infertility, it is always mandatory to perform a laparoscopy. Now, if it is pain, I am going to give a medical treatment in the form of NSAIDs, OCPs, progesterones. Remember, OCPs, progesterones, they never treat endometriosis. They do not shrink the endometriosis, but they are just going to treat the symptom of dysmenorrhea and menorrhagia. Okay. Surgical treatment is laparoscopy. You can do adhesiolysis. If the presentation of the patient is infertility, I am going to give ovulation induction plus IUI in cases of mild endometriosis, and if it is moderate to severe, I am going to go for an IVF. Okay. If it is an adnexal mass less than 5 centimeters, I am going to do observation. If it is more than 5 centimeters, I am going to do the surgery. So this flowchart I have made myself, and it is easier for you to revise the treatment part of endometriosis, which is definitely sure shot. There is always a question in the exams. Now next, there is an image given of the septate uterus responsible for recurrent abortions. What will be the best treatment? Always the best treatment is hysteroscopy. I am going to put in a hysteroscopy, and I am going to do the resection of this septum, but I am going to do it under guarded laparoscopy because while I am doing the resection of the septum, I might not perforate the uterus. So always the gold standard investigation in Mullerian duct anomalies remains laparo plus hystero when it comes to treating the patient. Investigation of choice for only diagnostic purpose. Nowadays, we do 3D ultrasound. So, 3D ultrasound is more preferred than MRI. One more thing, only if Mullerian ducts anomalies are causing recurrent abortions or infertility, only then you are going to treat. If it is just an incidental finding, please do not treat the Mullerian duct anomalies. One more thing, if you're dealing with a case of infertility or a recurrent abortions and you come across the Mullerian duct anomalies, always other causes of abortions and infertility you should rule out first. Fine. So this is an HSG image. Most likely it is a septate uterus, but you have to keep the possibility of a bicornuate uterus. The main difference between a septate uterus and a bicornuate uterus is in a septate uterus, this angle between the two cornua is an acute angle, and in cases of bicornuate uterus, it is an obtuse angle. Okay. This is an image of hysteroscopy, and hysteroscopically you are going to treat the patient. This is an image of laparoscopy. Why laparoscopy is done? Because differential diagnosis of this septate uterus is a bicornuate uterus. So laparoscopically you can do Strassman's metroplasty in case of bicornuate uterus, and for septate uterus the investigation and the treatment is hysteroscopic guided resection of the septum. Next, which antithyroid drug is safer in the first trimester of pregnancy? This is a very favorite or fixed question in FMG. Always remember it is propyl thiouracil because it do not cause any teratogenic effect. So in the first trimester this is preferred. From the second trimester onwards, the drug for antithyroid purpose is methimazole, and in the third trimester you can prefer carbimazole. Next, in hyperthyroidism, the maternal complications are usually thyroid storm, pre-eclamptic toxemia, preterm labor, high output cardiac failure because it is a hyperdynamic condition, then intrauterine death and IUGR. So that is the maternal complications and some of the fetal complications of the hyperthyroidism. So in the first trimester, it is propyl thiouracil. Second trimester onwards, it is methimazole or carbimazole. Now, why can't we prefer methimazole? Because it is a teratogenic drug and it can lead to esophageal or choanal atresia or aplasia cutis. Okay, even in the lactation phase, you can give propyl thiouracil. It is safe. Now, next question. All of the following are estrogen dependent except breast development, hair growth, change in the cervical mucus, or effect on the vaginal epithelium. Breast development, which is called as thelarchy, is the first visible sign of puberty in the girls. Although first sign of puberty in the girls is the growth spurt. Okay. Now, thelarchy is basically the hormone responsible for breast development is the estrogen. Estrogen also acts on the cervical mucus and leads to profuse abundant secretion from cervical glands, and if you make a smear, you will see furring of the cervical mucus. This is again an estrogen effect. Now, estrogen also act on the vaginal epithelium and causes changes. But hair growth is purely depending upon which hormone? It is dependent upon the androgens. Okay. So, hair growth is always dependent on the androgens. Now, remember in androgen insensitivity syndrome, axillary hair and pubic hair are absent, although there is testosterone, but it does not get converted into its active form dihydrotestosterone. So, this testosterone gets converted into estrogen. Hence, in these patients, there is breast development, but axillary pubic hair are absent because there is insensitivity to the androgens. One more thing you remember, for puberty changes, the classification is a Tanner's classification, which is used for puberty stages development. There are 5 stages for axillary pubic hair development and 5 stages for the breast development. Next, which of the following is a common duration of secondary postpartum hemorrhage? First of all, secondary postpartum hemorrhage is postpartum hemorrhage occurring after 24 hours of delivery of baby and placenta, and this condition is counted till 12th week of delivery. Okay, till third month of delivery, after 24 hours of delivery, this is the definition of postpartum hemorrhage. So it is 24 hours to 12 weeks of delivery, and the most common cause of secondary PPH is retained bits of placenta, which is suction chorita lobe. Retained bits of placenta, which is suction chorita lobe, and the management of this case is gentle curettage in the operation theatre followed by methergine or oxytocin. Now, I hope you remember oxytocin. This is something which is important. Oxytocin is a drug of choice for active management of third stage of labor. Oxytocin is a drug of choice to prevent atonic PPH. Oxytocin is a drug of choice for atonic PPH. Oxytocin is a drug used if there is breast engorgement, and oxytocin is very safe drug. Duration of action is only 20 minutes. It is very cheap and easily available drug. Okay, so you can use oxytocin by intramuscular bolus or by IV infusion. Should never give oxytocin directly IV because it can cause rupture of the uterus. So oxytocin is very, very important drug in obstetrics. 34-year-old female presents at 6 weeks of delivery, came for a contraceptive advice. Okay, came for a contraceptive advice, 6 weeks of delivery, and she wants contraception for next 3 years. What should be the best contraceptive in this case? So what is this? This is called as interval. After 6 weeks of delivery, if a patient is coming up for a contraceptive advice, it is called as interval. Okay, interval contraceptive. Fine. And this in the hint in the question is a spacing contraceptive. Okay, I am never in favor of lactational amenorrhea because you never know whether the patient is exclusively breastfeeding the child or not. In that cycle, if by chance ovulation occurs without menstruation and she is not using any contraception, the lactational amenorrhea can change into pregnancy amenorrhea. And sometimes if she comes for an MTP, uterus is very, very soft and you can cause the perforation of the uterus. So always it is advisable for the patients when they are coming in the postnatal clinic that you should always advise them to use the contraceptive method. So the options given to me here is copper T, IUCD with progesterone, injectable progesterone, lactational amenorrhea. So if you're using IUCD, what is the use of giving progesterone? Okay, so I am in favor of a copper T insertion, and widely used copper T in our country is copper T 380A. Effective period is 10 years. Failure rate is 0.6 per 100 women year, and it's applied freely. It's a government supply IUCD. Okay. Next, Which of the following drug is used in MTP for 20-year-old female who is in early weeks of pregnancy? So they are asking the abortifacient drugs which we use in the first trimester of pregnancy. Let us see the options. Okay. 200 milligram of mifepristone and 200 microgram of misoprostol. 800 milligram of mifepristone and 200 micrograms of misoprostol. Wrong. 200 microgram of mifepristone. Remember, mifepristone is always in the milligrams. So the correct answer is 200 milligram of mifepristone and 800 micrograms of misoprostol. Now let us see how it has been given. Now, if the period of gestation is less than 7 weeks, then mifepristone is given 200 milligrams oral. After 48 hours, it is tablet misoprostol which is given, that is 400 micrograms. Remember, oral, and this is followed by abortion near about 1 week. So if less than 7 weeks of pregnancy, this is the regime which is used, and you don't have to admit the patient. It is an OPD regime. Okay. Now, if the period of gestation is between 7th to 9th week, then we give tablet mifepristone 200 milligrams oral. After a gap of 48 hours, you give tablet misoprostol, which is prostaglandin E1, 800 micrograms vaginal, and we do not ask the patient to use the vaginal tablet, so it is to be inserted by the doctor. Okay, and also remember, whenever MTP by medical abortion or MTP by tablets is to be done, so it should be done within 63 days of last menstrual period, or within 9 weeks of LMP. Okay, more than this, it will be a chance for incomplete abortion. Fine. Next, a 24-year-old woman presented with cervix lying outside the vagina. Okay, so the cervix is lying outside the vagina. This is the vaginal introitus, and there is a cystocele present. What is the next step in management? When the cervix is lying outside the vagina, because of venous return gets obstructed, so there is a venous congestion, and that increases the chance for decubitus ulcer. Okay. In such a young female, if there is a genital prolapse, that means the support to the uterus is very, very weak. Since it is a very, very young patient, hysterectomy cannot be done. Now, what is Le Fort's repair? Le Fort's repair is done in elderly patients who are unfit for surgery. Say, age of the patient is 70 years or 80 years and there is a genital prolapse. So what is done is the cervix is reduced inside the vagina and anterior and posterior vaginal wall is stitched. But always do DNC and pap smear first to rule out any possibility of genital tract cancer. Okay. Anterior colporrhaphy is a surgery done for cystocele. So in this case, cystocele is an associated finding with cervical descent. When cervix is lying outside, the term used is cervical descent, and this is a 3rd degree cervical descent. Okay, so doing anterior colporrhaphy is just going to treat the cystocele, but what about the cervical descent? So in that case, I am going to give her a temporary relief and finally plan up the surgery. Okay. Now, pessary treatment is the one which is going to relieve this patient. So mostly it is the ring pessary. So this cervical descent can lead to the urinary difficulties as well as the coital difficulties as well as the defecation. Okay, so she might face the problem in urination or defecation or during the coitus. So ring pessary is the one which is going to reduce this. So according to the options given to me in this question, I am going to mark ring pessary as my answer. But otherwise, if it is a young patient, multiparous lady, then Manchester operation, that is a Fothergill operation, can be done, and leaving the uterus for the menstrual functions. Okay, if the age of the patient is suppose 50 years and there is a third degree cervical descent with a cystocele rectocele, my answer will be vaginal hysterectomy with pelvic floor repair. If it is a nulliparous prolapse where future fertility is desirable, then my answer will be sling operations. Fine. So when the cervix is lying outside, there may be a difficulty in the urination or in the defecation. Fine. Now, indications of pessary, pregnancy related, if she is planning to conceive during pregnancy, during purpurium, and sometimes even in the elderly, those who are unfit for surgery, pessary can be given. Okay. Now, if the elderly female with genital prolapse, I am going to do vaginal hysterectomy with pelvic floor repair. Pelvic floor repair means anterior colporrhaphy and posterior colpoperineorrhaphy. If it is a reproductive age group with multiparous lady, I am going to do a Manchester operation where there is an amputation of cervix followed by pelvic floor repair. If it is a young female with a genital prolapse, I am going to do the sling surgery. Fine. Next, a couple came to gynae OPD with infertility. On examination, the husband has gynecomastia and a tall stature. What is the possible diagnosis? Now, straight away, you don't have to go and look into the other options. Gynecomastia with tall stature is none other than Klinefelter syndrome. So in this, karyotyping can be done 47XXY. So this is a very straightforward questions. So karyotype here is 47XXY and sex chromatin is present. Turner syndrome is 45XO and it is a female. Swyer syndrome is a male with 46XY, but here there is undescended testis with a uterus. Undescended testis with the uterus present. Testicular feminization is 46XY. There is undescended testis, but external genitalia is female and there is breast development present. Fine. So, Swyer syndrome and testicular feminization syndrome are the examples of male pseudo hermaphrodite. And in both cases, the treatment is gonadectomy because undescended testis is a risk factor for testicular tumors. Fine. Patient is in case of breast cancer. She is put on tamoxifen. Now she is complaining of bleeding per vaginum. Always remember, tamoxifen is a SERM, selective estrogen receptor modulator. On the breast, it acts as antagonist, but in the uterus, it acts as agonist. So, when the patient is on tamoxifen, the risk for endometrial cancer is being increased. Okay. Ritodrin given to a pregnant lady to prevent preterm labor pain can cause all complications except the best tocolytic agent is always nifedipine, which is the safest, best and first line tocolytic agents to prevent the preterm labor pains. The second line tocolytic agent is beta adrenergic drugs. Beta adrenergic drugs like Ritodrine, terbutaline, isoxsupreme, etc. And very serious complication of beta adrenergic drugs is pulmonary edema. In addition, they can cause tachycardia, they can cause hypotension, so it is strongly contraindicated in heart disease patients as well as in diabetic patients. So, beta adrenergic drugs, the side effects can be tremor, side effects can be tachycardia, side effects can be hypotension, side effects, serious side effects can be pulmonary edema, but they never cause hypoglycemia, rather, they cause hyperglycemia. Now, why they cause hyperglycemia? Because the beta adrenergic drugs are steroids, and steroids affect the carbohydrate metabolism. Okay, so this I have already explained. Which anticoagulant is not used in the first trimester of pregnancy? Always you remember warfarin is not used because it causes teratogenic effect. So whenever anticoagulation has to be given to a heart disease patient less than 12 weeks, it is low molecular weight heparin, because heparin do not cross placenta. From 12 to 36 weeks, it is warfarin. 36 weeks to delivery, it is heparin, and after delivery, it is warfarin. Now, when in the last month of pregnancy, why you're switching over to heparin? Because it is seen if in the last month of pregnancy you are giving warfarin, it has increased the bleeding tendencies in the neonatal brain. It has increased the bleeding tendencies in the neonatal brain. Next, identify the case, image given. So, it is a very, very clear-cut image of placenta previa. Okay. So, I hope you remember all the points regarding the placenta previa. One thing I want to mention it here is, nowadays there is a radiological diagnosis, the investigation of choice for placenta previa. You can very well do the transvaginal scan. It is very, very safe. Moreover, you are not keeping the probe up to the, like touching, like the cervix and all that. So there is not at all any risk of bleeding if you're doing a transvaginal ultrasound. So radiologically, there are only two types of placenta previa, that is a low-lying placenta and another is placenta previa. Okay, so the marginal placenta previa, partial and central, they are all merged into placenta previa category. Choice of contraception, spacing between two pregnancies at least 3 years is always a COPT. So this is COPT 380A. You are supposed to remember the contraindications of IUCD. Now here I would like to mention upon the, so do remember, do revise the contraindications of IUCD. Contraindications, absolute and relative. So here I am telling you timing of insertion of IUCD. This is very, very important when you are writing an FMGE exam or you are writing a NEET PG exam. Timing of insertion. Number one is post placental insertion, that is within 10 minutes of placental delivery. Number two, post delivery insertion, that is within 24 to 48 hours of delivery. Number three, interval insertion, Interval insertion, that is after 6 weeks of delivery. 6 weeks of delivery. Now, after abortion or MTP, this is immediately. And number 5, if the patient is not a pregnancy case nor she is an MTP case, then what? Then as soon as she has finished her periods. So there are 5 categories for insertion of IUCD. Post placental, that is within 10 minutes of placental delivery. Post delivery, that is 24 to 48 hours of delivery. Interval after 6 weeks of delivery, immediately after abortion and MTP, or as soon as she finishes her periods. Next, identify the image. What is this image? Now, if you clearly see, this is the uterus, and there is a second level they are saying. And what is this? This is a urinary bladder. And if you see clearly, at the second level, there is a fistula. So it is likely to be the vesicovaginal fistula. Okay, so there are 3 levels of the fistula. So the second point is given, which is a vesicovaginal fistula. And the symptom of vesicovaginal fistula is true incontinence of urine from vagina. That is continuous dribbling of urine from vagina. She does not have any hold on this urination. Okay. So most common cause for vesicovaginal fistula in India is obstructed labor due to leading to pressure necrosis of urinary bladder. And most common cause of VVF in Western countries is gynae operations, especially Wardheim's hysterectomy for cancer. So most common fistula is vesicovaginal, and the cause is obstructed labor. Best method to localize the fistula is cystoscopy. So there are 3 swab tests which is done. It is also called as methylene blue dye test. But nowadays, this is not very preferred investigation. Preferred investigation is cystoscopy, because with the cystoscopy, you can know the site of the fistula, size of the fistula, and number of the fistula. Okay. If it is a ureteric fistula, then the investigation is IVP, intravenous pyelography. Okay. Now, till here was the first part of discussion. That is, I have discussed FMGE June 2022 exam and the Obs Gynae NEET PG 2022 recall I will be discussing in my second video. So stay connected.